I'm Lester Thompson, and it's a pleasure for me to be able to discuss some clear cell salivary gland tumors. As you know, salivary gland tumors are incredibly uncommon, representing 10,000ths of a general surgical pathology practice. As you know, they are most common in adults with fine needle aspiration utilized in most of the initial screening of patients, and molecular techniques have certainly caught on. If you look at the number of molecular techniques early on, you can see that there were only a few tumors identified, and yet now we have filled out the repertoire with several major canonical mutations and molecular alterations identified. I always like to think of tumors as a tumor site distribution concept, and if you think about major salivary glands and minor salivary glands, you can see that 75% of tumors occur in the parotid, 10% in the submandibular gland, so this means more than 85% of tumors occur in major salivary gland locations. When one looks at minor salivary gland sites, you can see that the palate is the most common, while others make up the difference. However, I think when you look at this particular approach by the diagnosis, you will notice that pleomorphic adenoma accounts for more than 50% of all of the tumors. And in fact, if you look at just benign tumors in general, for the major salivary glands, more than 75% are accounted for by benign lesions. Furthermore, if you now look at the distribution in minor salivary gland sites, you will see that in this particular location, again, pleomorphic adenoma is most common, but now more than 50% of the tumors are accounted for by malignancies. Therefore, as you think about benign versus malignant, and as a general rule, the smaller the involved salivary gland, the much more likely you are to be dealing with the malignancy. As you know, the World Health Organization has come out with several classifications over the years. This was the one from 2003, and yes, I was standing there. As you will notice, I didn't move at all as we moved into the 2016 classification, and alas, with COVID, all of us were virtual as we approached the various salivary gland classifications. When one looks at the 2023 World Health Organization classification of salivary gland tumors, you can see that there are several to consider. However, I would like to point out that in the 2005 edition there were 42, whereas now in the 2023 edition there are only 36. So even though new tumors were introduced, there was also an overall consolidation. I would like to point out that going to the online version of this classification is fantastic. All of the books are now hosted virtually, some of them still in beta form as they are about to go into print. As you also are aware, the ICCR, or International Cancer Collaboration, allows you to be able to do a standardized reporting of salivary gland neoplasms, and the new second edition has just been released, and you can, of course, go to their website and obtain this information as well. I think one of the most significant components of the updated WHO is the fact that all of the salivary gland tumors have now been incorporated into a single chapter, and I think this is a much more useful approach to it rather than necessarily having repetition in each of the anatomic sites that they exist. So importantly, if you go to the sinonasal tract chapter, you're not going to see any salivary gland tumors, and yet we all recognize that clearly salivary gland tumors do occur in this particular anatomic site, as well as several other minor salivary gland sites within the upper aerodigestive tract. I'd like to actually drive a case because I always think this is most illustrative, and then we will give a differential of the clear cell tumor category. 63-year-old who had a tongue lesion that grew over the past several months. You will notice that here is a fairly sizable lesion in the lateral and posterior tongue region. So let's drive this particular case. I think you will notice that there is a very large proliferation, areas of central degeneration. And then as you go up to slightly higher power, I think you'll see that there is a remarkable hyalinizing sclerosis that is present in this area, with a neoplastic proliferation arranged in cords and nests. When you look at it on higher power, I think you can see some of the cells are eosinophilic, while when you go into other areas, they certainly take on a cleared out appearance with a central prominent nucleolus. There's quite an infiltrative pattern around the periphery. So if I think about this particular case and look at a differential diagnosis, you can see that I have several different tumors listed here, and we're going to discuss each of these for just a few moments as I continue. But I think, first of all, if you lay them out in a grid-like fashion like this to contemplate the clear cell tumor category, you will notice that there is quite a remarkable overlap in the immunohistochemistry between each of these tumors. And what I would also like to point out is that as you look at these 4 lesions, all of these are accounted for by a single cell population, whereas you look at the other 5 neoplasms in this category, they are all accounted for with dual cell populations. And so I think the approach to this particular tumor category, if you look at it, is to try and separate between those that are single and 2 cell populations. So the diagnosis for this case is hyalinizing clear cell carcinoma, and that's what we'll discuss first. This, as you know, is a low-grade salivary gland neoplasm comprised of clear cells that have a variably hyalinized stroma and quite often are associated with some sort of EWSR1 rearrangement, which is not necessarily specific. There's several tumors that have this alteration. I think most importantly, it must lack features of other clear cell salivary gland tumors, so it's not really a diagnosis of exclusion per se, but you definitely do need to think of it in those terms. It's often unencapsulated, infiltrating out into the adjacent parenchyma, sheets and cords of monotonous epithelial cells that are variably cleared, and often with a very prominent cell border. Now, importantly, mucocytes and squamous differentiation can certainly be seen. Perineural invasion is very, very prominent in these tumors, and I will say that when you see necrosis, increased mitoses, or pleomorphism, you're much more likely to have a high-grade transformation present. Now, I've already showed this particular illustration as we were driving just a few moments ago from this tumor, where it has a very infiltrative periphery without necessarily having a capsule. When you look on higher power, you will notice that there are several nerves present in this example, and in fact the nerves are completely surrounded by the clear cell proliferation, as you will notice. The clear cells can be arranged in single cells or in cords or nests. Sometimes they have a more opacified appearance with even a suggestion of keratinization in the upper portions of this field. You will notice that the hyalinization is quite common in this tumor as well. However, that hyalinization will often compress the tumor into cords, and here you will notice very prominent intercellular borders between each of the neoplastic cells. There is quite a variation as you look at this tumor, where this particular field has a much more eosinophilic appearance and looks very much like a squamous cell carcinoma. However, as you move over, you will notice it takes on more clear cells, and then finally a whole boatload of clear cells are present in this particular image, which would suggest that you have a completely different profile. Sometimes the clear cells are really, really prominent and all that you actually see in the tumor without very much in the way of hyalinization. Mucus production can certainly be seen, as you notice in this field. Well, there are a number of different immunohistochemistry studies that can be performed, and again, it's because they're going to be highlighting one particular population rather than a dual cell population that it is of value. Importantly, molecular alterations with EWSR1 and specifically ATF1 as the primary fusion partner can certainly document the diagnosis. Mucin can be present, and so when you think about the differential with mucoepidermoid carcinoma, which we'll discuss in a few moments, you can see why it would be quite challenging. Very prominent and strong P63 or P40, while no reaction with S100, here just highlighting the nerves where you have perineural invasion, and of course smooth muscle actin is also non-reactive. As I already suggested, a molecular alteration for EWSR1 can certainly highlight the diagnosis. Let's go on now to a differential. I'm not really going to talk about sclerosing microcystic adenocarcinoma because it is so uncommon, but just be aware that it is a tumor that demonstrates a same sclerotic background material, but it will have both an epithelial and myoepithelial compartment associated with it, and therefore is a biphasic tumor, usually having an indolent behavior. So a low power, just to illustrate multiple cords and nests. When you go up to higher power, you can see that there is a squashed myoepithelial layer, and in fact, even on high power here, the presence of that myoepithelial lining with an otherwise dual cell population. Again, a very uncommon tumor, so I won't spend more time on that. Let's go on now to squamous cell carcinoma, because of course squamous cell carcinoma is by far and away the most common of all upper airdigestive tract tumors, and therefore does need to be considered no matter what. As you can tell here, there is surface origin in most of the cases with a desmoplastic stromal reaction as well. And again, it's going to be based on a single cell population. However, if I just looked at a single field like this with all of the clear cells and the prominent intercellular borders and bridges, you can tell how this would be a mimic for hyalinizing clear cell carcinoma. When you go into different areas, you will notice now there is keratinization easily identified, and in fact, in some areas, very prominent and well-developed keratinization with this tumor. As you can see, they often coexist adjacent to one another with areas of clear cell and opacified or eosinophilic cytoplasm seen in the same high-power field. So again, when you think about these neoplasms, just recognize that a squamous cell carcinoma can certainly be in the hyalinizing clear cell carcinoma differential consideration. Let's go on now to adenosquamous carcinoma. This is a tumor that is biphasic as well, where it has both squamous and glandular differentiation, recognizing that a few of these, especially in the oropharynx, will be HPV associated. Generally, they are two completely distinct areas that blend with one another, and surface origin is usually quite frequently seen. In general, it is my view that this is a much more high-grade neoplasm in general, rather than the low-grade tumor that you expect to see with a hyalinizing clear cell carcinoma. Here you will notice two different components. The squamous cell carcinoma is much more prominent, although you can see isolated areas of glandular differentiation as well, now becoming a little more better developed with the areas of glandular differentiation, and finally even showing ciliated cells that can be part of a malignancy within these tumors as well. Recognize that sometimes the squamous and glandular components will be juxtaposed next to each other like this, and you can tell that they do have a much more high-grade appearance than what I have shown previously. Again, mucin production is quite easy to identify, as you will notice here with mucinous differentiation in several of the neoplastic cells. Muci-Carmin will, of course, highlight the mucinous differentiation in this tumor that can help with the separation. And again, separating it from hyalinizing clear cell carcinoma is really based on a tumor grade in general with these particular tumors. Mucoepidermoid carcinoma clear cell type is probably the one that causes the most differential diagnostic considerations, and it is sometimes that you are required to go to do a molecular test in order to confirm the diagnosis. The mucinous and goblet-like cells, intermediate cells, and squamoid cells are quite frequent, and it's that intermediate cell compartment that is quite helpful. This is also a biphasic tumor where you do have two different cell populations present. MAML2 is most frequently identified, but recognize also that EWSR1 has been reported and certainly can be seen in the clear cell pattern. When I look at the overlying epithelium, it obviously can sometimes seem like it is arising from that space, and yet here you have a boatload of clear cells. As you begin to look through other areas, you can see that there is also an intermediate cell compartment along with the clear cells, and then finally a more mucinous differentiation with the intermediate and clear cells can be seen in an area that also has some sclerosis. The overlap is, of course, going to be with with P63 as well as CK56, as you will notice here. And so sometimes if you look at this particular tumor and are trying to separate it from a hyalinizing clear cell carcinoma, the only way in which you would be able to make a definitive comment in some instances is really if you do not have that biphasic presentation and need to do a molecular finding or a FISH study. MAML2 break-apart FISH would help you to confirm that particular diagnosis. I do like the idea that FISH is actually derived from a gene in jellyfish when they have phosphorescence under the water, and thought you would enjoy that particular slide. Let's go on now to myoepithelial carcinoma. As you know, this is a single pattern of a clear cell myoepithelial population. This has a very diverse architecture as well as multiple different cytomorphologies, which is why it is included in the differential. And as you know, the EWSR1 is quite commonly identified within clear cell tumors. However, it will show both epithelial and myoepithelial differentiation, something that you do not see in hyalinizing clear cell carcinoma. So here you will notice clear cells, abundant clear cells with some background myxoid to degenerated stromal compartment with a very strong and diffuse pan-cytokeratin and P40. with even CK5-6 present in many of these tumors. However, when you do S100 or SOX10, and in fact, even if you do calponin, will give you a strong reaction in many of these neoplastic cells, helping you with the separation. Just as a point of clarification that INI1 is intact in salivary gland-related tumors, which is an interesting finding when compared to soft tissue-related neoplasms that do not have that. When you put them side by side like this, I think you can see that, again, there can be some overlap, but with the myoepithelial carcinoma having a single cell population as well, but showing myoepithelial differentiation. Epithelial-myoepithelial carcinoma is one that has a clear cell compartment as well, and it is a clear cell biphasic neoplasm, where the myoepithelial cells are surrounding the areas of glandular differentiation. So the interluminal ductal cells are the ones that help with separation. A biphasic presentation will be seen with both the epithelial and myoepithelial markers here, with many of these tumors having a RAS oncogene present. As you look at a high-power field like this, you can see that there is hyalinizing background sclerotic material, with also having a clear cell population. But as you begin to move around, I think it's quite easy to identify that you begin to have small areas that have gland-like differentiation or duct-like differentiation within them, surrounded by the hyalinizing clear cells. A low-power field like this certainly highlights that particular finding much more easily and readily. And then when you go into a different area, I think you can see that there is an epithelial central ductal compartment surrounded by the cleared myoepithelial cells. Sometimes the myoepithelial cells will predominate, and you'll have a really strong population of them in a single or in several fields in a row, and so that can cause some confusion. When one looks at the immunohistochemistry, you can see that the CK7 nicely highlights the ductal epithelial cells, while any of a variety of different myoepithelial markers will highlight the myoepithelial element, giving you that dual or biphasic presentation, and so the separation of an epithelial-myoepithelial carcinoma from hyalinizing clear cell carcinoma can be easily achieved. Let's go on now to acinic cell carcinoma, and I'm really only including it because sometimes acinic cell carcinoma can have a combination of a wide variety of different cells, where normally one has this fenestrated type appearance, but it is made up of several different components. So the serous acina cells, or the very large polygonal cells, are what we usually consider, but intercalated duct type cells, non-specific glandular cells, clear cells, and even vacuolated cells will be present in this tumor to a variable degree as well. So when one has a field like this, the serous acina differentiation is very easy to identify, versus an area like this where there's a much more glandular appearance to it, and then finally an area like this in a tumor where all of the cells have a clear cell morphology to them, and in fact it is quite difficult to be able to highlight areas of acina differentiation, although if you go into high power you can begin to see that there are some areas that maintain slight granularity in the cytoplasm. As you know, the PAS will be positive with diastase-resistant zymogen granules, with a variety of immunohistochemistries helping, especially with DOG1, SOX10, or NR4A3. However, it is going to be a generally single-cell population that is positive, and the NR4A3 is one of the most recurrent rearrangements identified in this neoplasm. When a PAS is performed, it's usually a luminal accentuation of the granules, as you see here, with a similar finding in a canalicular arrangement with DOG1. However, NR4A3 in the neoplastic cells, while not in the adjacent acina component, and then of course when you look at it in a high power field, you can see that every one of the nuclei are positive. One of the nice things about this stain is that it is identified irrespective of the tumor grade, so even when you have high-grade transformation, you would still be able to confirm the diagnosis. So again, clear cell change in acinic cell carcinoma versus a hyalinizing trabecular carcinoma can often cause some difficulty, and yet the immunophenotype would be able to help you in that interpretation. Well, renal cell carcinoma is, of course, one that does need to be considered no matter what, because, of course, metastatic disease to the head and neck area can be identified with salivary glands frequently affected. However, it gives you a very alveolar architectural pattern with extravasated erythrocytes quite easily identified with the prominent cell borders. And again, this is going to be a single cell population, but other than overlap with CK-pan and CK7, the PAX8 and CA9 would be quite different. So here is an example of a clear cell renal cell carcinoma giving you a slightly vacuolated appearance to the cytoplasm. Another area here with marked extravasation of erythrocytes in an alveolar architecture. And just to highlight a single very strong positive reaction with CA9. So as I think about the very broad differential diagnosis for clear cell tumors within the salivary gland, and these 9 specifically, I would like to say that if you look at all of the first letters of those, it's hammers. And of course, it's always fun to end with something saying, no matter what you use, just remember that everything becomes easier when all you have are hammers to look at. I hope that you have enjoyed this presentation, and I'll be happy to answer any questions as they may be raised at this time. Have a great day.